Good afternoon or morning, depending where you are. Welcome to the Fibromyalgia Association Canada's monthly presentation. I'm Trudy Flynn, Chair of the Board of Directors of Fibromyalgia Association Canada, or FAC as we like to call it. I'm going to keep my comments brief so we can get right to the presentation. Thank you for joining us today. If you're not a member of FAC, you can join at the link that's in the chat. And FAC is committing to growing our membership for our advocacy work because there is power in numbers. Excuse me. And together we are stronger. So before we get started, I would like to cover a few housekeeping items. If you have any questions for Wendy, please put them in the chat and we'll get to them in the question and answer segment of the presentation. We have closed captioning enabled, so this presentation is being recorded for those who could not attend at this time and for our YouTube channel. All participants, please mute yourself and also turn off your video so only the presenters will be in the video. So let's get started. I'd like to start by saying that although people attending may be spread across Canada, I am in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. And migraines and fibromyalgia co-occur a lot with people experiencing both conditions simultaneously. So we know what fibromyalgia is. It's a chronic disease with widespread musculoskeletal pain and fibro fog and fatigue, while migraines are more than just intense headaches, way more than that if you experience them. They are throbbing, pain, nausea, sensitivity to light and sound, and so much more. The overlap between the two is significant, as both involve nervous system dysregulation that heightens that pain sensitivity. We seem to feel it more. People with fibromyalgia are more likely to suffer from migraines, probably due to the triggers like stress, lack of sleep we suffer from, and the changes in weather. Managing both conditions often requires a holistic approach, including lifestyle adjustments for many of us, medications, and therapies to help ease the pain and improve the quality of life. Wendy, I'm going to let you introduce yourself. I am so happy to have you here. Wendy is from Migraine Canada, and it's just really appropriate that the week after Pain Awareness Week, we would come to discuss just another type of pain, right? So absolutely. I will turn it over to you, Wendy.
Really excited to be here talking to the group at with fibromyalgia. It is very common that the conditions do coexist, so I'm happy to be here, and I'm also happy to learn more about fibromyalgia as well. So let's get started. So I just want to start with a couple things. What's included in this presentation is just information. We do not provide medical advice. Anything that might be discussed may not apply to your own medical situation. And as always, I'm sure you've heard this many, many times, always discuss medical treatments with your own healthcare provider. So what are we going to cover today? We're going to cover what is migraine, what is the impact of migraine, why is there a coexistence, the treatment options that are currently available, and what else can be done. So Trudy asked me to focus on treatment options, and due to the amount of time we have today, my presentation will not dive into the science behind how medications work or why they work. We have many, many different types of webinars already recorded on various topics, so I won't go into detail of these. So I encourage you, if you want to learn more about certain medications and how they work, or why they work, that you can check out our YouTube channel. What we will go over is what is available, the evolution of options that we have in Canada, and I'll also talk a little bit to access, because I know accessing medications can always be a challenge no matter what condition you have. So what is migraine? Trudy did a great description earlier. Migraine is a neurological disease. It is largely inherited. It involves nerves, blood vessels, and neurochemicals. It is, like Trudy alluded to, it's an increased excitability and sensory processing. It's increased sensitivity of pain pathways, and the migraine brain is very different. Migraine is common. It impacts about 15% of the population. It exceeds that of osteoarthritis, diabetes, and asthma. It is more dominant in or prominent in women by about 25%. And it does impact men around 8 to 10% as well. More than 3 million women and 1 million men live in Canada with migraine. And these are just some different statistics that 1 in 10 children, 1 in 7 people, 1 in 4 households are impacted by migraine. So the World Health Organization has deemed that migraine is one of the most prevalent neurological disorders. It is the second leading cause of global disability. It is the most prevalent medical illness. And if you look here on their disability classes, the WHO has migraine listed as a disability as severe as acute psychosis or quadriplegia. Migraine is more than just a headache. I know I hear it time and time again that, oh, it's just a really, really bad headache, but it's so much more. And for those of you that are on this webinar today, you know that it is. It involves many of these other symptoms and that it's not just a bad headache. So what does this mean? Migraine is not your fault. A lot of people will blame themselves that they've done something to bring on the disease, but in most cases, it is not your fault. It is a neurological disease that involves attacks or flare-ups of symptoms. And I'm just going to quickly skim through a couple of these slides because Trudy already touched on it, but it is commonly coexists, fibromyalgia and migraine. It is a central sensitizations plays a role in both. Both are invisible and highly debilitating. A combination of conditions shows increased sensitivity to pain. Both conditions have a huge impact on quality of life. Migraine, I think, similar to fibromyalgia, is not well diagnosed, and effective treatment is not typically offered very quickly. So how are fibromyalgia and migraine related? So there's been some studies that indicated that found like a 55.8 prevalence of migraine among fibromyalgia patients. And then there's been other studies that show a prevalence of fibromyalgia in migraine patients to be over 30%. So as Trudy alluded to earlier, it is very, very prevalent in both conditions. And it's a bit of a cat and mouse thing. Is it the migraine that triggers the fibromyalgia, or does fibromyalgia really trigger the migraine? So there's not enough research done to have a better understanding of that. So as we talked about, we're going to get into the treatment options that are available. And I'm just going to mute this. So the treatment options. So what can people do to optimize the management of migraine? Treatment is truly like a puzzle, and it often doesn't include just one thing. I put this slide up here because I just wanted to talk briefly about the frequency and the continuum of migraine. So migraine is a spectrum disease, and it can be low frequency for some people, and for other people, it can be very high frequency and highly disabling. About 80% of people who live with migraine fall into the low frequency category. You'll see that right over here. Close to 15% are still episodic, but have a higher frequency of migraines, and they fall into this middle section. And then about 5.5 to 6% have chronic migraine and usually have more headache days than not, and can be very highly disabled. And I wanted to mention also that some medications are prescribed for episodic and some specifically for chronic, and we'll get more into that in a few slides. So migraine preventives, oral medications that were options before Botox and the the CGRP antibodies. So these were older medications that were used prior to this little tidal wave of the new medications that we now have. They were actually prescribed off-label, which means that they were researched and developed to treat other conditions, so like depression, epilepsy, and seizures. And it just happened that they were found to be helpful in treating migraine. And so because there were no medications for migraine, clinicians just went with what was kind of working. But like I said, these medications were all off-label. So we're going to get to the 4 revolutions of migraine treatment that exist now. So like I said before, there were no medications researched and developed to treat migraine. So the triptans were the first to come to market, and they were designed to treat migraine in the 1990s. To this day, they are still prescribed, and for some, this is all that they need. They don't need to transition into more specialized therapies. Botox was the next to come, which was in 2011. It is injected every 3 months and is highly, highly effective for many people. Then in 2018, the CGRPs came to market. These are game changers for many, many people. They are injectables on a monthly or an infusion every 3 months. Like I said, these medications were researched and developed to treat migraine. They're safe, they're effective, they're well tolerated, and we now have 4 available in Canada. And then more recently, we had the gepants come to market. So this is a new class of medication as well, and they entered the market in 2022. We now have 3 available, with a 4th coming, I think, in 2025 or 2026. But we have 3 to get us started on this class of medications. These are oral daily medications, and we have 3. We have Nurtec, Ubrelvy, and Qulipta. So I just wanted to quickly go over acute medications. So acute is often referred to as a rescue medication, taken daily or as needed. And some examples I've listed are triptans, NSAIDs, gepants. And it's really important to treat early with acute medications, to limit the use to 10 days per month, and we'll get into why this is important, and to also track use, and we'll get into in the next slide why that's important. So medication overuse headache is a real thing. It is caused by prescription or over-the-counter medicine. So like your triptans or your NSAIDs. NSAIDs are your over-the-counter medicine. And it has 3 effects. It makes migraine less effective over time. It causes dull, persistent head pain between migraine attacks, and it can cause the disease to progress, leading to more frequent migraine attacks in the long term. Those most at risk of developing medication overuse headache are people with migraine who have 10 or more headache days per month and treat each attack with medication. So essentially, we want to limit the number of days that we're taking medication, and if your headache days start to increase, or you're needing to take medication more than 10 days per month, you might want to have a conversation with your physician and talk about maybe exploring a preventive treatment option. And I want to also emphasize to people that medication overuse is not anything to blame yourself about. It is just something that is very common that happens, and there should be no blame or guilt put on yourself if you happen to go into this medication overuse headache phase, which can be resolved as well. So preventive treatment options are really meant to reduce the frequency and or intensity of your migraine attacks. Oral daily preventive medications are pills, and they include the antidepressants, antiepileptics, beta blockers, and now new to the market, the gepants. And then the injections are the CGRPs, which are once a month. Or if it's infusion, then it would be every 3 months. And I just wanted to talk a little bit about first line medications, second line and third line. So I'm going to show you very quickly a slide following this one that just outlines that generally speaking, physicians or clinicians will start with first line drugs, which are proven to have more efficacy than second line, and then second line more efficacy than third line. So it's important to understand that as the evidence decreases, as you move down the line of prescribing these medications, patients will have to go through different levels of trying these medications and failing before you can get to a more specialized drug. So this is just a very quick example when we talk about first line, second line, third line. So your clinician would start you on a first line medication, likely try and fail on a couple of these before they would go to a second line or even a third line. And in most cases, with most payers, you have to try and fail on at least 2 of these first, second, or third line medications before you are eligible to try for and be covered for a specialized drug like the CGRPs or the GPANs. So I just quickly wanted to go through what CGRPs and antibodies are. So the CGRP means it's a calcitonin gene-related peptide. It is a protein that is naturally present in our bodies, and it plays different roles, including pain signaling and blood vessel dilation. It plays an important role in migraine, so researchers have started to find ways to treat migraine. And then what is the antibody part of it? The antibodies are naturally present in our bodies. They play a role in our response to infections and inflammations, and antibiotics can be used as treatments designed to specifically block proteins in our bodies. Okay, so what I've done is I've sort of put together this slide based on the recommendations from the headache clinic guidelines. And this is from the old guidelines. The new guidelines were just released last week, and I haven't had a chance to completely update slides and even my understanding of what changed in the guidelines because I was on vacation last week. So essentially, you would want to start and stay on these stronger recommendations and avoid moving into like products that have a weaker recommendations. So here you'll see that we have the GPANs and we have the CGRP medications and of course Botox. And you will see that there are some other indications for like an antidepressant or an ACE inhibitor beta blockers as well. But like I said before, the game changers right now are really the GPANs and the CGRP medications. So we have many options available, which is a great thing for people living with migraine, but we want to make sure that we're not leaving out sort of, and Trudy alluded to this, that it's not just all about the medications, that we do have to have some behavioral changes and lifestyle modifications also adopted in our lifestyles to help with the disease management. So sleep, exercise, diet, hydration, reducing stress, pacing, coping are all really important. It's also really important that we clarify diagnosis, that we get medical help, keep a headache diary. I'm going to go into that a little bit more, and that we learn about the treatment options that are available, and we learn how to have conversations with our physicians about that. We talked about the acute medications, so acetaminophen, NSAID, triptans, antiepics, GPANs, talked about preventives. The one thing we didn't talk about yet was procedures, which is neuromodulation devices, nerve blocks, facet blocks, that kind of thing. So lots of options that are available to us in Canada. And I just want to talk briefly about a little bit about the non-pharmacological treatments, just because they're so important to to me, they're as important as the pharmacologic treatments. So supplements, nutraceuticals, we have magnesium coenzyme, petadolics, vitamin B2, neuromodulation, we have cephaly and gammacore and Dr. Ho. We have adjunct therapies that can include ice packs and heating pads and peppermint oils. Lifestyle tracking changes is really important way to implement and sustain your migraine journey. Stress and mood, we have CBT, relaxation, mindfulness, meditation, biofeedback counseling. All of those things can play a role in helping you on your journey. And of course, physical or occupational therapy can also be of help addressing postural issues, TMD, that kind of thing. So really, really important that people spend time on this slide and making those changes that they can. So Trudy asked me to, one of the common questions that comes up is what's available in Canada versus in other countries? And I found this information from the World Migraine Summit that kind of pulled together and compared what's available in certain countries. Of course, it's not every country, but it gives you an idea. So CGRPs, for the most part, we're on a pretty even playing field as the other countries. All of the CGRPs are covered in Canada with the exception of Aimovig by the provincial drug plans. But Aimovig is covered by a lot of the private payers, except for those that mimic the public drug plans. And the reason why Aimovig is not covered by the public drug plans is because their negotiations at the Pan-Canadian Pharmaceutical Alliance didn't end with a letter of intent, which means essentially drug plans would not cover those that medication. But the other ones are covered in every province. So that's the uptake on that was really good and not bad in terms of timing. So GPANTs. GPANTs again are newer to market. So we're starting to see provinces listing. I think Ubrelvy is no, Qulipta is covered pretty much straight across the country for preventive and for acute, not preventive. They just got their negotiations at Pan-Canadian Pharmaceutical Alliance just finished, so preventive will be coming. And then you'll see that Nurtec is available, and as is Ubrelvy, and Zavegepant has not been submitted to Health Canada yet, but that will be an option that will be coming available in Canada in the coming years. Devices, just quickly wanted to talk a little bit about that. So we have two devices that are available in Canada now. So cephaly and gammacore. They are not available through the public drug programs, and they are not, unfortunately, covered by private insurers to the best of my knowledge. But it's something that eventually we want to work on. We have so many things to advocate for and change. But I would love to see private insurers covering these just as they do cover devices for other disease areas. Nerivio is something I believe is coming to Canada. I actually have in my long to-do list a follow-up to find out when that manufacturer will be bringing them to Canada. I know lasmiditan is something that a lot of people ask about, and it currently is not available in Canada. The reason for that was there was some labeling issues between Eli Lilly and Health Canada, and Eli Lilly made a decision to not pursue it, and so that's why it's not available in Canada, but it is available in the States. So right now, another manufacturer is going to start marketing Emgality, which is one of the CGRPs. And so they may be interested in pursuing this with Health Canada again. I'm actually meeting with that manufacturer for the first time next week. So I'll have more information on their intentions with lasmiditan. Yeah, and so there's where we kind of fall a little bit short compared to other countries in terms of coverage of other medications. Triptans are pretty on par with other with other countries. This information that I got from the World Migraine Summit only listed these two, but for most part, triptans are pretty available in Canada, and we'll go over what that looks like in a couple slides. So what is the importance of medication access? So I'm just going to go through a couple slides talking about what access to treatments actually look like in Canada. It's one thing for medications to, as you know, be approved in Canada, but it's another thing for them actually to be reimbursed and actually getting them into your medicine cabinets. So in 2023, we commissioned a first ever report card that we launched in January of 2024. And the purpose of the report card is really to give a comprehensive overview of what access to care and treatment looks like across Canada. It's not a light read. It's it's about 75 pages. It includes a comprehensive overview of migraine, epidemiology, diagnosis, economic impact. And we go into like the number of neurologists that there are in Canada. We talk about what products are covered by province. We talk about criteria. So it's really, I call it my Bible. It's just a comprehensive overview of what care looks like and what we need to improve. So the other thing I'll just add in is like, this is not something that is like a one and done. It's something that we'll continue to update, and we'll do other addendums to it. Like for example, in 2025, I'm hoping to do an environmental scan similar to what Migraine World Summit did, and explore what options are available in other countries, what is the criteria that's involved, and just see how Canada as a country compares to other other countries. So as you can see here, Botox has not great access in the publicly funded formularies across Canada. It's only really available in Alberta, in Ontario, and Quebec. And then CGRPs again is, this is a little bit outdated, this slide. All of the CGRPs are available in every province with the exception of Aimovig. And then here is the example about triptans. So triptans have a bit of a mixed bag of coverage. In a perfect world, we would strive to have this grid completely green, which would mean like open access. And the reason why we would want it to have open access is that people need to try and fail on at least 2 of these medications in every province in order to actually get to be prescribed a specialty medication. And so where you see like flat out no's or SAs, which is special authorization, these create barriers for people, right? So either if I'm a person and I live in Alberta and I want to go on Relpax, for example, I have to pay out of pocket. And I have to do that in order to get onto eventually like a CGRP or a GPANT. So we would really want to see this grid green to eliminate and remove all the barriers that people have to go through to get onto specialty medications. And as part of our report card, we do have 16 recommendations in over 3 different areas: knowledge, improve management, improve access to treatment, that we are really committed to making a reality across the country over the course of the next little while. So what else can you do? Migraine, like fibromyalgia, is invisible, and it is invisible for migraine on an MRI, but very visible on a headache diary. So really, really important that patients track your symptoms. We have the Canadian Migraine Tracker app, if you're not already familiar with that. It is free. We also have downloadable headache diaries. We have ones that are 2, 3, and 5 month diaries. And again, I really can't emphasize how important tracking your journey is. The information that you track helps both you and your healthcare provider make informed decisions about your treatment plan and your journey overall. And additionally, there's more and more payers that are starting to request that this information be provided to either be approved or have your medications renewed. So really, really important. Okay. The other thing I just wanted to mention, I'm sure with similar to fibromyalgia, is really beware of medical claims and useless testing. Make sure that you know, does it make sense? Is it safe? How much does it cost? And who recommends it? There's a lot of things out there claiming to work, including surgeries, devices, naturopathic cures, miracle diets, manipulations, and that kind of thing. Just really do your homework and just beware of those kinds of things. Repeat blood testing for migraine and imaging is just not necessary because it doesn't show anything. So I just wanted to bring that up and bring it front and center. And so for key takeaways for today is really each person with migraine needs an absolutely personalized plan. What works for the person sitting next to you may not work for you. Migraine management is complex, so you really need to be very patient. You need to be open to trying new things, and don't give up hope. That is something we always tell people is don't lose hope. Migraine is influenced by many things. Each requires consideration. You need allies and medical guidance in order to manage migraine. It is a chronic disease and is generally a lifelong journey. So finding that balance place and what works is really, really important. There is no fairness to this disease. It is a brain disease. It is. There's no fairness. I can't emphasize that enough. We just talked about being aware of pseudoscience and fake claims of miracles. There's some situations that are extremely difficult, but there are more options available now. And again, just stick with it and keep having conversations with your doctors. Let them know what your goals are, set realistic goals, that kind of thing. Be open-minded and explore the medications, procedures, and devices and behavioral modifications that we've talked about. Be your own self-advocate. Take medications as prescribed. That's really important as well. And I just wanted to share with you, we are having a webinar on December 2nd with Dr. LaRue, who will go into detail about what the updated headache treatment guidelines are and what it means to Canadians. So we would love to have you tune into that webinar on December the 2nd at 7:30 p.m. Eastern Time. We have a ton of information on our website. So I encourage you to explore our website, which is migrainecanada.org. And be sure to check out our PDF library. It has information on all of the treatment options, all of the non-pharmacologic treatment options as well. If you're not already a member of our community, please join our community and help us grow and build our brand. We are a very young organization. We were only founded in 2018. So we're still growing and people are finding us, and we want to really be the voice of all Canadians. So we hope that you would find value in being a part of our community as well as the fibromyalgia one. Yeah, join our community. Follow us on social media. There's our website. We're on Facebook, Instagram, LinkedIn, TikTok, and I guess I should say X now, but Twitter. So please follow us. This QR code can be scanned and it'll take you to a page where you can sign up for the webinars and for a direct link into the PDF library, and also a link to join our community. And thank you to everybody for registering. Can't emphasize enough how much knowledge is power. It truly is. See our events page to register. Follow us on social media again, and sign up to be a member of our community. And with that, stop sharing. And hopefully I didn't talk too quickly, but I wanted to make sure we got through all the slides and had time for any questions.
So for anyone who has a question, please put it in the chat. I do have some questions myself. Diet seems to affect my migraines, I will say. And so can you speak to the role of diet or hydration in managing or preventing migraines?
Yeah, we actually have a really good webinar that we held a couple of years ago that goes into depth about how different types of foods can impact migraine. I don't have that information on the tip of my tongue, Trudy, but it definitely plays a significant role, as does hydration. Can't emphasize how important keeping yourself hydrated is. I hear from people regularly who end up going to the emergency room because they're not hydrated enough, and I think that's a simple fix, is just making sure we're getting the right hydration into our body. Always have that water bottle with you, and make sure that you're regularly drinking.
So are there some specific foods that are known to trigger migraines, like chocolate, red wine? Those are the ones I've always been told about.
Yeah, I think those are pretty standard ones. Some people will argue and say, like, well, caffeine actually helps my migraines, doesn't make them worse. Never heard anybody say red wine helps, so I think that's something that people would want to avoid if it is a trigger. I think overall, like we talked about, is it's migraine is very personalized. So what might work for, like, what might trigger something for one person may not be a trigger for another person. Like, I've heard people with migraine say, no, chocolate does not a trigger for me, and then other people it is. So it's really hard to say, but we do have a webinar that I would encourage if you want to learn more about how nutrition plays a role, to take a look at our YouTube channel, and the dietitian that gave that webinar dives into it pretty deep.
That's great. Actually, that's a good resource because it really, listening to you, Wendy, makes me really realize how much fibromyalgia and migraine have in common. We're both young organizations, and we both are invisible illnesses and we both have difficulty accessing treatments in Canada that are paid for, that are known to help by the people in the community, but not recognized by the people who need to recognize that those kind of things should be funded. And also, I think migraine probably has the same invisible disability to it, so doctors don't always accept or believe, especially if you're not having a migraine when they see you.
Yeah.
How are they going to believe that you actually suffer from migraine, right? So I'm sure members of the migraine community, which to me overlaps with the fibromyalgia community. I know personally it took me a long time before I had any treatment for my migraine. My doctor just kept telling me it was my fibromyalgia, but I knew it was way more than that. So I think, correct me if I'm wrong, but people with migraines have a difficult time getting diagnosed as well.
Yeah, it takes a lot of time to diagnose, and there's a lot of misdiagnosis.
Yes.
Yeah,
Um,
I think there's a statistic, and I should know this, but on average, it takes like really 5 to 7 years for somebody to get that diagnosis. It's quite lengthy.
Mhm.
In part because a lot of the healthcare professionals receive very little training or education on migraine in their various programs, whether it's pharmacy program or medical school. So that's part of what we're trying to do, is really provide information to healthcare professionals so that they're expanding their knowledge base so that they can better help and treat their patients.
And that's very similar again to fibromyalgia. There's very little time spent on chronic pain, and all that little time spent on chronic pain, very little of that is on fibromyalgia. So I assume that migraines are in that same chronic pain kind of category, and very little time spent on it. So, are there sometimes there's lesser known symptoms. So we in the fibromyalgia community have identified almost 200 symptoms that
Oh, wow.
can be in some way related to fibromyalgia. Is migraine like that too? Are there lesser known symptoms that someone might not think they have migraine, but actually it's being overlooked because it's just a lesser known and it's not on the list of here's what to look for?
I I don't I really can't answer that. I don't think so, but I could be wrong. Like, I'm not a healthcare professional, so
Hmm.
um I think mostly what I hear of is the common ones. I don't regularly hear of something like that I'm taken aback by, saying, "Oh, I've never heard of that before." They're pretty the common ones, so
Yeah.
I can certainly look into that a little bit more and maybe get back to you with that, because that's an interesting question.
So when I first started having migraines, and I've had other people tell me this too, I didn't really get that I need to go to the emergency department because I can't handle this pain. I didn't get that. I got this kind of dull ache, but so much nausea, so much sensitivity to light. And my doctor called it an aborted migraine. And unfortunately, it progressed through the years, and now it no longer is an aborted migraine. It's a full-on migraine. So is that common? Like for it to at first be kind of what I would consider, well, actually, it still was debilitating because if you're nauseated and you're sensitive to light and you
Yeah.
have to go into a dark room, it's still debilitating.
Yeah.
But the pain wasn't there. And now, is that common to move from um, minor a minor inconvenience to a severe inconvenience?
Yeah, it definitely can. It's like the disease just progresses, right? So
Yeah,
it's not uncommon. Yeah.
which is kind of like fibromyalgia. You know, the longer you have it, it kind of progresses and you develop more and more symptoms. So, but it's amazing how much our communities are alike.
Yeah.
So it's valuable that we, have presentations like this so people realize, because a lot of people with fibromyalgia don't realize that it's related, that there's a comorbidity kind of one to the other, right?
Yeah.
So we do have a question. Is vestibular migraines common?
Yeah.
She's my full blown migraines now flip flop with vestibular migraines.
Yeah, I don't actually have a statistic to throw back at you, but definitely vestibular migraine is very common. And I think Dr. LaRue did a presentation on vestibular migraines, I'm gonna say in the spring. So you might want to check that out. Like, she did an entire presentation on just that. And that's what you know, probably similar to fibromyalgia, is that each of these topics are generally a webinar in themselves, just because there's so much information that we can share back. But check that out for sure, because I know Liz would have, Dr. LaRue would have like thrown out some stats and that kind of thing, but it is very common.
Can you tell me what is a vestibular migraine?
Oh, a vestibular, I should have the definition down. The best of my understanding is it creates maybe Corey can understand can explain it better. It's more about like balance and you like and eyesight and that kind of thing. So it's um some people will say it's more debilitating actually than other symptoms of migraine, but it's yeah, it has its own little definition and that kind of thing. But I think overall that was sort of the summary of it.
So balance and
Yeah,
vision
and visual. Yeah.
and less pain, more of that and
I
less
would
pain.
not say less pain.
Okay.
Yeah, it's
I
all
only ask,
personal, right? Like,
yeah.
there's some people who have less debilitating vestibular migraine, so they might have less pain. Um, Other people will still have a lot of pain with it, and like Corley is adding in like dizziness and balance and nausea. So I wouldn't
Hmm.
minimize symptoms from it by any means, because in some people it's worse, right?
Well, it's interesting because when I look at that, I wonder if my doctor's aborted migraine diagnosis was really vestibular, because that's kind of what it was. It was more visual, more dizziness, more balance, and definitely nauseated. So it's interesting, right? Even the medical world doesn't, they don't, I'm not going to say they don't keep up, but are they aware of new medications and new treatments, do you think, on average?
So we're talking specifically about primary care providers, I'm assuming.
Primary care, yeah.
So I would love to say yes, but I think, I mean, primary care providers treat so much, right? Like
Yeah.
it's impossible for them to know a lot about everything, right? As my son is he just graduated medical school and he said, family doctors are awesome. They're amazing. He said they know like a little to quite a bit about a lot of things, but they don't know everything and they can't be
Yeah.
expected, right? Which is why we have specialists that they refer on to. And specialists know a lot about a few things.
So
So
is there a specialist for migraines?
there is. There's not many. We probably, in our report card that I talked about, I should know these numbers. Like, there's under 1,000 neurologists in Canada, but not all neurologists treat migraine. In fact, very few treat migraine, and I have come into interactions with some who are like, I don't treat migraine at all. But there is probably, I'm going to go out on a limb here and probably say under 50 or maybe around 50 who are headache specialized or specialists, like Dr. LaRue, who founded Migraine Canada. She is a headache specialist. That's all she sees. She doesn't see stroke and she doesn't
Yeah.
see epilepsy. She's a headache specialist. So not nearly as many as we would hope there would be. And that's just the reality of it.
Well, once again, I understand that because we don't have any specialist in uh, fibromyalgia, and the rheumatologists who do see fibromyalgia patients are very few and far between. So,
Very so.
um,
Yeah.
yeah, yeah. So that's interesting because I would have assumed that all neurologists dealt with migraine, but because it's so common, right? You
Yeah.
just assume that.
Yeah.
And that's
Yeah.
interesting.
I think it's
There,
also migraine is like probably like fibromyalgia is it's time consuming. Like it takes
mhm.
a lot more time with patient trying to diagnose, trying to find the treatment option. Um, so yeah, it's just and there's no test that says, yes, you have migraine. Like there's no, right? So it's a time-consuming disease to manage.
Yes, exactly. Again, the same as fibromyalgia. So, well, thank you very much, Wendy. This was really interesting, and I knew that fibromyalgia and migraines were related, but it it was surprising how much we have in common, actually. And so, really appreciate your time today. And
Oh, my
if
pleasure.
thank you so very much.
My pleasure. Thanks for having me.
Bye, everybody.